So thank you everyone for coming and taking the time out of your busy schedules. I know most of the people in the audience, but for those who I don't know, my name's Sumit Gupta. I'm one of the pediatric oncologists here, and I'm the chair of something called PERCC, which you'll hear more about as the hour goes on, or the unit for policy and economics research in childhood cancer. And it's my pleasure to introduce four really very knowledgeable and experienced speakers who are going to form our panel today. Quickly, I'll let them introduce themselves in more detail, but Dr. Ramandeep Arora is a senior consultant pediatric oncologist at the Max Super Specialty Hospital in New Delhi, India. Avi Denberg, most of you will know as well. He's a pediatric oncologist here and the health policy chair at PERCC. Carlos Rodriguez Galindo needs no introduction, but he's a pediatric oncologist at St. Jude's. He's the head of the International Oncology Program, or I'm getting the name wrong now. It's changing, right. Obviously has a very large footprint in the pediatric oncology world. And Dr. Ali Landman is a senior editor with the Lancet Oncology. So I'll take about 5 minutes to sort of set the topics that we wanted to talk about today, and then each speaker, each panelist, I should say, will speak for 10 minutes as well, and then we'll open it up to about 20 or 25 minutes, depending how much time we have at the end of just back and forth question and answers. We're keeping this very informal, no slides, nothing like that. We're just sort of, this is a forum to discuss various thoughts. Can I ask for a quick show of hands? Who would say that they, in their day-to-day working lives, works in the field of cancer, not necessarily international work, but childhood cancer, either clinically or research-wise? Okay. And who would say that they work in the area of global child health, either again, research or clinical-wise? Okay. And who would say they work in the intersection of those two? Oh, so again, that's the topic, so it's not surprising there's a few of you, but you can see that even in this audience, when this is the specific topic, there's not a lot of people who work in the intersection of two, and that's because it's a very non-intuitive for most people intersection. The number of times I've had my own family and friends say, well, that's a thing, right? Like, people actually treat childhood cancer in low middle income countries. But the data is becoming more and more clear that as strides are made against infectious causes of childhood death in many countries, childhood cancer becomes the next most common disease-related cause of death, and it comes up and up and up in the priority setting agenda. Combined with, and that mirrors what we've seen in the adult world too. There's a big push for non-communicable disease control in these settings as well. So at the moment, some of our best estimates, although they're based on data that's not of the highest quality, is that about 275 to 300,000 children are diagnosed with cancer globally every year, and 80% or more of those actually live in low middle income countries where the cure rates are far, far lower than what we would expect here in Canada, where we cure about 80 to 85% of those kids. So when people started to first get involved in this field, and St. Jude's was, of course, a trailblazer in this, the predominant model was something called twinning, where a high-income country individual or institution partnered with a low-middle-income country individual or institution, and there was this bi-directional flow of knowledge plus or minus resources to try to improve the quality of childhood cancer care in the low-middle-income country setting. And there have been some amazing, amazing successes chalked up through that model. But I think what's become very clear over the last 5 or 10 years is that that model is very limited and has a very low ceiling in what can be accomplished at a population level. And so in order to have a greater impact on the population level and the global burden of childhood cancer, we really need to start talking about health systems, health policy, and what impacts and what systems we need to put in place there. And so that's really the focus today. So Raman is going to speak about what he sees in his day-to-day life treating these kids with cancer, about how the strengths and the weaknesses of the health system actually impact that day-to-day care. Avi is going to talk about what we can do in terms of research in this area. Again, most of us are very familiar with basic science research or clinical trials, but research at that sort of health systems level is a little bit less intuitive to many of us. Carlos is going to talk about what St. Jude's has done in this area, which is obviously a tremendous amount. And then Ali is going to talk about what the Lancet Oncology in past commissions has done and what their experience is and how to galvanize advocacy and health system change through various of their commissions. Throughout this, I should stage set as well, we at PERCC, collaborating with St. Jude's, with Dana-Farber and Harvard, with the UICC and other partners around the world, are coordinating the Lancet Oncology Commission right now on sustainable childhood cancer care in low-middle income countries. And the whole idea behind that is to build an investment framework that can be used as both information and advocacy tools to really move this agenda forward. And that's why we're lucky enough to have all these individuals here. So with that, I will not say anything else, and I will invite Raman to start us off.
Thank you, Sumit. So my name is Ramandeep Arora. I'm a pediatric oncologist. I'm based in Delhi. I'm grateful to Sumit and Carlos and the entire Lancet Oncology team, commission team, who have given us me the opportunity to come here. What I'm going to, I don't have a structured talk. I have just jotted down 4 or 5 words which I think I would like to touch upon and share with you what they have meant for me and how they apply to the daily work we do. My background is, I'm a pediatrician from India. I went abroad to UK. I was there for 11 years. I did my clinical training there in pediatrics and pediatric oncology, and then I did some research in cancer epidemiology. But probably what was the most important lesson over there was understanding systems, understanding the importance of research, understanding audits, understanding how you can make a difference. And to start with, I would state the obvious, which is what Sumit has said, that you can have 80 to 85% children with cancer cured with appropriate treatment, but with 80% of countries not having access to that level of care or that level of outcomes, the challenge, or it's a no-brainer to say that if you can provide the same outcomes to the 80% children who don't have those outcomes, the impact which you can make, the lives you can save, is so much greater. And that's the motivation or the drive behind people who are either based in low-middle income countries and working there, or people who are in high-income countries and reaching out to people and trying to make a difference there. So the first point I want to talk about is perspective. And what I mean by perspective, this is that most of us as pediatric oncologists are, of course, focused on the individual. We are focused on the detail. If you're doing research, we are focused on that molecule or on that drug or on that target. But some of us have the desire and the inclination to focus on the bigger picture. And neither is right or wrong, it's just a question of interest. And I think with you, many of you being interested in global health, it is obvious that you're looking at the bigger picture. And when I worked in England and I work in India now, what I find is that majority of the clinicians are outstanding, devoted, dedicated clinicians who are not looking at the bigger picture. I may be incorrect, people may disagree, but that's my perspective. And if we want to work in such a field and we want to make a difference, we have to ask us, it would be nice to have that quality where we are able to treat the patient, but also look at what happens when they go home, what happens to my country, what happens to my state, what happens to my city, what happens to my world. So that's the first thing I want to share, which is that as a clinician, if you have that bigger perspective, you are likely to enjoy or do better or learn more in the context of childhood cancer. The second thing which resonates with me a lot is the whole concept of access to care. And I think if I had to find the single most important challenge in pediatric oncology in low-middle income countries, it is access to care. And when I say access to care, I don't mean in the narrow concept of, can you access the hospital or so on. Access to care, I think, extends much beyond that. It is, of course, access to your general practitioner or your primary care person. It is access to the hospital, transport, etc. But it's also access to, once you reach the hospital, do you have access to the scan? Do you have access to the radiation machine? Is it working? Do you have access to safe blood products? Do you have access to food? Do you have access to transport? Do you have access to lodging? Do you have access to social insurance? Do you have access to survivorship program? Do you have access to a polite doctor? So you can make it as broad a term as possible. And so when you see that there are challenges at every level of access to care, the solutions have to be found for every level of those challenges. And there's a term which we use in the pediatric oncology global world, which is abandonment of treatment. And many of us in this room and others have worked a lot in the last 10 years to bring that concept to the forefront. And people now recognize it as one of the main causes of treatment failure in children. It is essentially one aspect of access to care, of failure of accessing care. The third thing which I wanted to mention is the importance of research. Now, I'm sure for those of you who are in pediatric oncology over here, who are seeing patients, enrolling them on various clinical trials, you would say that, whether a patient of leukemia or lymphoma or Wilms tumor or Langerhans disease, whatever, you've got, in most cases, a trial open where the patient can enroll. And you're not doing the trial just for the sake of doing a trial. You know that research leads to better knowledge, but also improves patient outcomes. And there's data to say that participating in cooperative group studies and research projects actually improves outcomes. So the interesting experience for me was that when I was in England, around 80% of patients were on clinical trials. When I joined my hospital in India, 0% of my patients were clinical trials. So essentially, I had to use a protocol which I was familiar with, but I was working in isolation, and I continue to work in isolation. So one of our focuses in India currently is to develop multi-center prospective clinical studies. And we've had some success with that. So in the last 3 years, we have kick-started the Indian Pediatric Oncology Group. And in the last 2.5 years, we have 23 multi-center studies in development, 9 of them which are actually recruiting. So today, if I have a patient of ALL or Hodgkin's or AML, I can offer them a clinical trial in my hospital, which I didn't have 2.5 years ago. And the way we want to see this develop is that in 5 to 10 years' time, I have 80% of my patients who are eligible to go into a clinical trial. The last thing I want to allude to is the fact that underpinning all this is data. Without collecting data, whether incidence data or survival data or hospital episode data, intervention data, etc., you cannot measure anything what you're doing. And so this concept is being recognized by all stakeholders, and whether you're in India and you've got, so not only do you have to have an Excel sheet or a computer or an online software like Pond for Kids or IndiaPod or whatever, you also have to have a data manager. You have to have somebody funding that. And that is well recognized by people who fund these things. So with that, I kind of close my few thoughts. One is the perspective, look at the bigger picture, look at the country as a whole, look at the state as a whole. Second is access to care is probably the single most important challenge, and it is all-encompassing. It's a very broad term. Third is cooperative group research, carrying everybody with you, trying to answer questions is one critical way of improving outcomes. And the fourth thing is data underpins all of these. Thank you.
Ending, Raman, on data is a really nice segue to a little bit more detailed talk about research in this area, and that's what I want to spend a few minutes on. But a step back from data for a sec, I really want to capitalize on what Raman said about access, because really that's the inspiration for, I think, the work that many of us do in this field. It's all about seeing the patients that we care about get better access to care, and it's a recognition that going beyond the individual patient is sometimes necessary to do that. So to have that macro lens, to scale up towards a health system, towards understanding the country in which care is delivered a bit better, and to understanding all the things that go into those various and manifold dimensions of access in order to get better care to the patient at the bedside. So I think that's the inspiration that is behind this commission, for which many of us are here, and it's behind a lot of the work that we do at PERCC and that many of us do in this field, and that no doubt many of you do. What I would challenge us to think about, and probably many in the room have, is at least in pediatric oncology, and this is probably not the case for many of those in global health and some other domains, I don't think we've done a very good job at all at going beyond the bench and the bedside. We have tended to focus most of our energies in research in either the basic science realm, the translational realm, or in the context of clinical trials, and that's completely appropriate and necessary. Where there's a paucity of literature and of inquiry is arguably in the world of health systems, And there are some other domains in global health and in other disease states where people have done this with more rigor and a little more thoughtfully. And I think we'd stand to gain from thinking creatively in childhood cancer and in the childhood disease state of your choice about how to incorporate some of that knowledge and some of those methods and richness of experience in terms of expanding how we understand how childhood care is delivered in whatever setting, high income or low, and how to improve it. So I'll give you a couple examples of the work we're doing at PERCC to try to do that. What I'd really love to come out of this is not a laundry list of some projects that are cool that we're engaged in, but some inspiration hopefully on your part in terms of getting involved in some of this work in whatever field you're in. And if it's pediatric cancer, come talk to us, so much the better. So at PERCC, by way of a couple of examples, I think the overall mission is to really try to understand the health systems within which childhood cancer programs and services sit, to understand the macroeconomic and political contexts that are kind of the surround for that care delivery, and to see how childhood cancer programs can interface with those systems to improve them in a sustainable way. This becomes, and we've talked about this a lot in the context of the Lancet Commission, a really important and crucial thing to think about in the context of broader global health priorities, such as Sustainable Development Goals, and you guys will be very familiar with those. If we're going to latch on to narratives about universal health care and sustainable improvements in health for kids broadly across the world in various settings, we're going to need to think much more broadly about health systems, politics, and economics in terms of improving delivery of care and access to it. So a couple of examples of projects. One thing we've spent some time developing at PERCC and with partners in a few Latin American countries, notably in University of Santiago in Chile, with our partners at St. Jude and with core collaborators at Harvard, is a tool that's geared towards assessing childhood cancer systems from a policy analytic point of view. That is very specific to childhood cancer, but also takes broad account of the surrounding health system and political context. There are similar kinds of frameworks that try to account for health systems more generally, and there are even some that have been developed with a bit of specificity to other disease states, but there's no such thing in existence as yet for pediatric cancer. So we've developed this instrument, we've validated it, we've field tested it, and we're in the process of rolling it out more broadly in a variety of LMIC jurisdictions to really kind of map childhood cancer systems there. And that's forming a part of the commission in which we're all engaged. So we've done that in 5 different LMIC settings. Most recently for the commission, we've also have supplementary data from a partnership with University of Chile and 12 other Latin American countries where we've generated now both qualitative and quantitative data on different aspects of the health system to try to understand them. So that's one sort of example of kind of policy analysis or systems analysis work in which we're engaged. Another big focus is economics, so economic evaluation. And we've undertaken a few different studies to either try to cost childhood cancer care in a given jurisdiction, or to actually do analytic work to understand cost effectiveness. So not just the costs that accrue when either building up or sustaining a childhood cancer program, but also those costs relative to the effects that they produce. So notions of economic efficiency, right? Bang for buck, what you're getting in for what you get out. We've done that now in a few countries, among them El Salvador and Ghana, where we had a couple students and collaborators engaged in doing this work under the leadership of Sumit and Sue Horton and others. Sue, I should mention, is another person on our PERCC team who is a global health economist from the University of Waterloo, very experienced in this field. I've led a Burkitt lymphoma microcosting exercise or cost effectiveness study in Uganda at the Uganda Cancer Institute with some partners from Fred Hutch and the UCI, the Uganda Cancer Institute. And the reason I mention these is not just to plug projects, but to say that these are sort of first-in-kind studies in childhood cancer. No one has done these sorts of things before. But we're drawing on well-worn methods in other fields, adapting them appropriately for our context, and seeing results that I think are going to be really instructive for policymakers and program managers in those health system contexts in terms of making decisions about which health conditions to prioritize in budgets, recognizing scarce resources, and from an advocacy point of view, how to actually make the case for childhood cancer system strengthening in those contexts. Far across the board, what we're seeing is that by international standards of cost effectiveness, investing in childhood cancer treatment is actually hugely cost effective. And predominantly that's because of the outsized gains that accrue to curing a child with cancer at a young age, who can live, for all intents and purposes, a very healthy life for a long time. So not only is the research interesting, it's also hopefully a policy, has policy relevance and potential impact at the level of the health system. Those are some of the big examples I wanted to put out there. And again, I put them out there not to speak specifically only about those projects, but to suggest that if you're engaged in global health in a particular disease area, and these are methods that haven't been brought to the fore for your population of interest, that's doable. There's ways of leveraging existing methods to do novel work in child health in a variety of these domains where it's been done less, arguably, than in adult health for many of disease states. And that's a really rich and interesting area of research with impact for population health. So I think I'll stop there because I think, Carlos, are you next?
Yes.
And that leads nicely into maybe a description of St. Jude and the broader Lancet Commission.
Thank you, and thank you, Sumit, for organizing this interesting table. So I was thinking as I was listening that probably I'm the most senior in this table. And so I thought it would be a nice idea as well to start by telling you how I got into global health, because I am a pediatric oncologist and my training was bread and butter pediatric oncology. There was no global health at that time. I mean, I'm not that ancient, I'm not a dinosaur, but the point is that global health as a discipline for research and for capacity did not exist, honestly. I wanted to be a pediatric oncologist, and my career has been in pediatric oncology. I'm a clinical researcher, clinical and translational researcher, and that's how I built my career, for what it's worth. But that has been in clinical care, clinical research, translational research in pediatric oncology. But I always was interested in global health. Global health, when I was training, was basically mission relief work or infectious diseases, communicable diseases. That was just the post-HIV era. I think that's what global health was. But I was training at St. Jude, and St. Jude had started that outreach program, the international outreach program that Sumit was referring to, which was basically relief work, was the twinning model, trying to help programs, wherever these programs were in the spectrum of development. And it was a very philanthropic, very humanitarian, very generous initiative that lasted for many years. And with that, St. Jude developed these twinning partnerships with many countries in Latin America, Middle East, Asia, etc. So during that time, I grew as a pediatric oncologist, and I volunteered, I would say, in the outreach program just because I speak Spanish and I liked that. And so little by little, I got more engaged. I was hosting, when I was a junior faculty, many of the doctors that would come from Latin America, particularly from all over the world, to spend 1 month or 2 months at St. Jude. And that was very valuable to me because I was, I had the opportunity to really talk firsthand with the people that were in the trenches working on these, and that has developed friendships that have lasted forever. I was a junior faculty; they were junior residents, and if you have been in Memphis, you cannot do much. So if you come for 1 month to Memphis, you really need to take care of the people that come to Memphis, meaning going to the grocery store, going to restaurants, going to the movies with them, because there is not much to do. So, bottom line, that kidding aside, I got involved and then helping with some of the programs. I would travel to some of the programs, but was always like on my spare time. I had to ask time off to do all these things and host these people. My career was, basically evaluated on my performance as a pediatric oncologist. So then many years later, I left to Boston, where I continued to do my clinical and translational research, but then I kept that drive. I needed to continue to do global pediatric oncology because I had been doing it for so long on the side that I felt that this was too important to me. And then I realized that over my career, what I really wanted to do is to cure children with cancer, period. That what I was doing was just dropping of water in the ocean, that what I was doing at St. Jude, at Harvard, was really not impacting the lives of so many. And I wanted to honor my own dreams, which was to cure children with cancer. That pushed me to do more global, and I came, when I went to Boston, I started a global program as well in Boston that forced me as well to think in a different way, in more an academic way, looking at the entire spectrum from health systems to care delivery. And then a little over a year ago, maybe 2 years ago, I just was invited to come back to St. Jude to then try to help kind of reorganize the program at St. Jude. So for me, it has been a journey over 20 years of, going back to global, when this is probably what I wanted to do when I was a medical student, but there was not a way to do that. So now what we are doing at St. Jude is try to bring this twinning model to the next level. And Sumit said very rightly that, the twinning model has a ceiling, and that ceiling is pretty low. St. Jude has built around 24 programs in 17 countries with that twinning model, and that allows us to reach out or touch, if you wish, the lives of around 3% of all children with cancer in the world. But that's nothing, and that's not scalable. We cannot continue with twinning with everyone. So we are reorganizing the program so that it's scalable, and to do that, first we have transformed that into an academic program, which was not before. Before it was just a program on the side. So now it's a Department of Global Pediatric Medicine with faculty that we are recruiting at all levels, and from health systems down to quality improvement, health economics in the future, ethics, etc. And build this with a whole different flavor. So the next step has been to redefine what is the IOP. We did not, when I came, I realized I did not like the word international, I did not like the word outreach, and I did not like the word program. So we had to come up with a different name, and what I really wanted is that St. Jude would become global, so that St. Jude as an institution, St. Jude Children's Research Hospital, with our vision that no child should die in the dawn of life, would make that vision global. So basically we were very blunt, and we said, okay, this is going to be St. Jude Global, and that's what we are calling ourselves, St. Jude Global. Basically that means trying to engage the entire institution into including global pediatric oncology as part of our vision and mission, which is not easy, but we are trying. And so basically that's everyone, not our department, but everyone else, from facilities management to help us then define, what are the key, components of a basic unit in pediatric oncology, right? To get pathology or get pharmacy or nursing. So basically, St. Jude as an institution will develop these global goals, and we as a department are basically the conduit for that. And then at a programmatic level, we are, we're still maintaining these twinning partnerships, but little by little we're migrating to more regional networks, so that allows us to reach out to more children and develop initiatives at the regional level, at the national level, and at the program level. Obviously, at the regional and national level, we're talking about health systems, as Avi was referring to. So basically, we are engaging very much into that as well, how we can strengthen the health systems, how we can strengthen these regional networks, so that then we can filter down all these initiatives to the bedside, with all the metrics being at the patient level. So obviously there will be metrics at the health systems in terms of what we can accomplish, but what really matters is how many children we can reach and how many children we can cure. And that's basically how we will filter these three levels. So with that, being part of the commission has been great, because it has helped us redefine some of our tools and posit and profile to help us see what are the strengths and the weaknesses of whatever we are working. These regional networks will just be for capacity building, but for the entire spectrum, from health systems to quality care, and we develop different initiatives based on where they are in the spectrum. But then we also will use these networks as a conduit for research. So not conduit for us, but conduit as well for the program. So we understand that research is a key element in growth, and it's a condition sine qua non for advancing care in children with cancer. So you have a research department, St. Jude has research in its name, so we cannot think that there are two different levels, that we do research, but research is only for us. So global health has to get involved in academic aims and be engaged in research. So basically what we're trying to do is teach the research model. So it's a lot of implementation science at first, but then little by little you advance with interventional studies, measuring interventions, etc. And for that we are supplying the networks with the research infrastructure in databases, data management, education for clinical investigators, data managers, etc. And then the third component is education. And so we cannot build capacity without investing in human resources. And so we are investing, capacity, financial capacity as well, in what we call the St. Jude Global Academy, and that means helping train the entire, the healthcare workforce spectrum, from nurses to doctors, pathology, social workers, etc. So we're developing initiatives for all these areas, and we have 4 or 5 initiatives. One is a distance learning platform, which we have had for many years, that is called Cure for Kids, and now it's going to go through a lot of changes, more to provide material that is closer to graduate school type of material, so with certificates, diplomas, etc. And then kind of hands-on training programs with fellowship training programs around the world. In each one of the regions there will be fellowship training programs, as well as nursing education hubs. And then what has given name to the academy, which is St. Jude-based 3-4 week workshops for infection control, palliative care, pathology, neuro-oncology, etc., etc. And these are hybrid models that individuals will sign up, get 3 months of online teaching and education to accomplish some minimum goals, and then come to St. Jude for 3 weeks for hands-on discussions, additional training, and then develop programs. So this is more or less how these 3 components will be set up: education, capacity building, and research. And so that's about it for what St. Jude is trying to do. And obviously we understand that this cannot be done alone, and so St. Jude is engaged in developing partnerships with as many other players as possible, globally and nationally.
Thanks. Hi. I'm Dr. Ali Landman. I'm a senior editor at the Lancet Oncology, and I'm the handling editor for the Sustainable Pediatric Cancer Care Commission. And it's really exciting to be here at SickKids on behalf of the Lancet Oncology, and I want to thank Sumit and my fellow panelists for giving a really great overview both of the problem of cancer care in low and middle income countries and the work of global pediatric oncologists, the work that they're doing and trying to do in the future. And I'd just like to shift gears really quickly and summarize why the Lancet Oncology thinks it's important and why we've embarked on a partnership to create this commission. So, as has already been highlighted, the burden of cancer is increasing in low and middle income countries, but most of these countries and regions are not equipped on multiple levels to deal with the growing burden. And the Lancet Oncology believes, and I'm sure most of you believe as well, that it's not enough to just talk about this or even publish on it. Research into epidemiology of pediatric cancer worldwide and how communities and nations are tackling the issue is really important, but alone it's not enough to affect change. And we want to translate this research into action, and to do that, we have partnered with experts, like the ones seated with me, in pediatric oncology and global cancer control for the Commission. So the Lancet Oncology has a long-standing interest in global oncology issues, and we've showcased this with our commissions, of which we have published 7, covering topics ranging from region-specific cancer control planning and challenges in Latin America, China, Russia, and India, and modality-specific recommendations regarding equitable access and implementation of radiotherapy, surgery, and primary care in high-income and low and middle-income countries. And broadly, all these commissions include, either implicitly or explicitly, the provision of care for pediatric patients with cancer. We also have a successful series program that highlights specific issues in cancer control around the world, including a series that we published in 2013 on improving cancer care for children and young people. So why a commission? A Lancet Commission acts like a white paper or a government advisory report, and its purpose is to address questions of unmet need and act as a forum to bring together leading global experts to propose and discuss solutions to the problem. And it can serve a lot of purposes, including adding new analyses and defining problems and gaps in healthcare access and proposing solutions to those gaps. But the most important product of a commission is actionable and measurable goals to improve, in this case, pediatric cancer care worldwide. And the commission will not only systematically review existing research, add new research, but provide novel recommendations for how clinicians, communities, governments, regions, nations, and even intergovernmental organizations for how they can make a difference and know that their actions are actually good value for money. So that's the cost effectiveness aspect. So in addition to helping focus the commission and ensuring that it's scientifically rigorous and useful for clinicians and policymakers, the Lancet Oncology works to promote the commission through press and media activities, conferences, launch events, encore events, through the commissioners and their institutions, and we work in partnership to keep the message and the momentum going through a number of channels, print and online. And this is really important because it means that we're disseminating the message far and wide to the people that we hope can act on it. And sometimes this leads to a really great opportunity to revisit commissions and revisit their recommendations and their results. And we were lucky enough to do this with our Latin American Cancer Control Commission. So that was first published in 2013, and then we published a follow-up commission in 2015. And the second commission was able to highlight the progress that had been made, but also areas where challenges remained and new issues that had come up in the interim. So we're really aiming to change policy and guidelines, and we've had success doing this already with several of our commissions. For example, the Global Radiotherapy Commission, which was published in 2015, has been adopted by ESTRO, and the IAEA is incorporating the findings into their guidelines. And the Latin America Commission, which I just spoke about, was welcomed by health ministers and national cancer institutes in many countries in South America, and it's led to engagement with those clinical and policy communities. So we hope that together with the commission group, the Sustainable Pediatric Cancer Control Commission will generate specific recommendations that will achieve measurable improvements in and benefits for children with cancer around the world. So I appreciate you taking the time to listen to our plans and discuss the ideas that we have around global pediatric oncology. And because engagement with this community, with the pediatric oncology community, is so important to its success, I'm sure that your thoughts would be really appreciated. I'm sure Sumit would be happy to hear from people about that. So thanks.
I'll open it up to the audience. We've got some mics that I think Halit and others are going to rove with. But if anyone has any specific questions, please feel free to start. Stan, start with you, and then Helen.
Sumit and panel, wonderful discussions, really interesting. A couple comments, going to question. Dr. Aurora, you talked about the three most important things you were dealing with were access, research, and data, and I certainly agree with all of those. But one of the words you didn't use when you talked about access to care was the word quality. In fact, the word quality actually wasn't used, I think it was used once by the panelists. So there is a difference clearly between access to care and access to quality care. So I wonder if you might want to comment a little bit about the issue of quality, not just access. First question. And then two other quick issues. One is, although Sumit wasn't on the panel, what he said at the very beginning was really interesting, and that is that when he talks to his family or his friends about global cancer, they're a bit surprised because I think there is a general impression that cancer is either rare or very expensive to treat, and that if you're going to do that in a low or middle income country, it's an unusual undertaking to take on. So I noticed in looking at the agenda for your 3 days for the commission that you did not have communication as one of your major topics of focus. And I think actually you're doing yourself a disservice, thank you, a disservice by not also focusing on communication, because as important as looking at the cost effectiveness of an intervention, which government officials may think are important, most people in the public couldn't care less about that. And you have to communicate to the public in order to get the politicians to do something. So I think a focus on communication would be really important. And if you allow me one further comment, we have a program in 6 English-speaking Caribbean islands. It's a sustainable capacity building programs on oncology and blood disorders. And what's amazing about that program is the entire program, the first part of the program, the first 5 years was a $7 million program. It was paid for by philanthropic donations, and all the donations, virtually all the donations were from the Caribbean. So I also think it would be worthwhile for the Commission to think about how you're going to pay for some of this, and look locally and think locally about philanthropic support for what you're doing. Thank you.
Thanks, Dan. As usual, all spot on, right on the money. So a few thoughts, and maybe the other panelists will chime in. So I think your question about quality, to take the first one, is really crucial. And we couldn't speak to everything in this session, but you're right, we probably should have mentioned that. It's something that we're giving some serious thought to in the context of the Commission explicitly. So as part of the tool we've developed to analyze health systems, we're also doing a fairly systematic review of quality indicators or performance indicators for childhood cancer systems. There's been some elegant work done, actually led by POGO, the Paediatric Oncology Group of Ontario, to do that in the Ontario context, which with some degree of transferability to other high-income country contexts, but it doesn't transfer that well to most other contexts. And so as part of this exercise, we're going to not only survey that literature, but literature on performance indicators in child health and global health more broadly, with a view to also do some expert consensus work around them, with a view to having some quality indicators to measure performance of childhood cancer systems in LMICs. So you're right, quality is crucial. With respect to communication, maybe I'll let Sumit speak a bit to this, but in the day tomorrow, for our commission work, there's going to be some time and discussion set aside to messaging and advocacy. But it's a great moment to take pause and think about communication, not only to the funders that we'll be engaging with and to governments, but also to the public. As part of this systems analysis tool that we've built, there's an embedded module on information, education, and communication with the public, recognizing the sort of crucial nature of that to diagnosis and referral for children with cancer, for symptom recognition, et cetera. But in terms of messaging to the public more broadly about this as an important health issue, absolutely crucial. And you're right, part of the, some of the cost effectiveness stuff may feed into that, but it's not enough. And then lastly, I was remiss to not mention SCI and the SickKids Caribbean Initiative and some of the stuff PERCC is engaged with. Partly I didn't mention it because some of the stuff that we're going to partner on from a research perspective is still going to roll out and is at early stages. But I think I, for one, and I know Sumit, we're really looking forward to further engagement with SCI on doing some of this kind of policy and health systems analysis work. Some interesting stuff came out of the empirical data on country case studies this morning at our sessions, one of which was on, in, for instance, El Salvador and Guatemala, the absolutely crucial nature of foundations in leveraging funding for sustainability or the building up of the programs of childhood cancer in those contexts. So you're absolutely right, looking domestically for those funds and trying to leverage those where we can in country will be crucial. I don't know if others want to.
Just very brief, two very brief comments because we will not have too much time, but the quality is key. And so basically we define our program as measuring patients that have access to quality care, and so that will be our metric. And we are developing a tool for actually measuring quality regardless of your level. And the other point I wanted to comment on is the funding. I think it's critical, and so St. Jude has tried to do, because we have twin, the hospital has twin, but as you know, St. Jude has a very powerful organization behind that. It's ALSAC, it's a foundation. So what we try to do is what we call ALSAC Global, meaning matching what we are trying to do. ALSAC, the foundation, try to build capacity locally for fundraising, parents organizations, etc. But then we realized how difficult it is to raise funds in some of these programs. And initially we thought, there will be enough resources locally to actually make these programs sustainable, but it's extraordinarily difficult. And so when in many programs we thought we're going to be there for, say, 5 years, 10 years, and then the local foundations will take over, and we cannot leave. Even with the more successful of the foundations in Guatemala that are raising several $1 million a year, we still cannot pull the plug, and we still provide a lot of the funding. So yeah, I think it's critical. I don't know what is the formula for that, but definitely we need to think about how to make it sustainable.
So thank you for this panel discussion. It's always great to come to a talk about global health and cancer, because there's not enough of these sessions. My question is about the commission itself, and something that resonated me from Dr. Landman's talk was how Lancet Oncology really wants to push research into action. And I can't help but notice that the commission is composed mainly by oncologists. So is the underlying assumption that it's the oncology team that pushes research into action? And I wonder if there's any patient representation. Here at SickKids, we have a budding patient engagement strategy and a family committee, and I'm hoping that those things have been considered by the commission.
Yeah, I can start with that. No, definitely. I think that the majority of the people are probably pediatric oncologists, but we have health systems experts, we have patient advocates, we have parents organizations. So we have tried to put together a very comprehensive panel of individuals. Maybe what you see these days in Toronto is more biased towards the pediatric oncologists, but definitely I think we have tried to put as many members of the continuum as possible.
If I can add just one thing to that too, I think one of the lacks that we've all run into is the fact that most of us are clinical pediatric oncologists, and so we have a very easy time convincing each other that pediatric oncology is important, right? We wouldn't be pediatric oncologists otherwise, and so very much for this commission, we're trying to make sure that the messaging doesn't fall prey to that. So for example, there's a group of either current or former ministers of health from various low middle income countries who have agreed to review the commission once it's in a more concrete package to make sure that the messaging makes sense to them, because again, that is going to be a key, if not the key, audience, and then similar processes in place from a patient advocacy point of view as well.
Thanks for taking time out of your busy meetings to meet with us this afternoon. I have a question about human resources for health, more specifically maybe in your health systems analysis tool. What kind of things are you looking at in terms of the health workforce? Is it specialized education, interprofessional practice, density of health workers? I'd be curious about that.
The easiest and shortest answer is I can send it to you, and you can see all the domains that are covered. There's 2 different tools that have been developed, one here at PERCC and one at St. Jude, to try to map health systems. One does a pretty sort of transits up towards the health system more broadly and looks at it horizontally, and another one takes a pretty deep dive into childhood cancer facilities in low and middle income countries at various stages of development. The latter one, which is the St. Jude profile tool, has a whole bunch of domains on the health workforce, looking at all those things that you mentioned and more. What the POSIT tool does, these acronyms, the POSIT tool means Pediatric Oncology System Integration Tool, and I can never remember profile.
There's an ongoing joke that none of us can ever remember what profile stands for, but
I don't know if that's a good acronym or a bad acronym. In our health systems, the broader health systems tool, this POSIT tool, in addition to looking at things like health workforce density, modalities of training, accreditation, etc. We're also looking more broadly at priority setting and policies that guide health workforce capacity building and training more broadly than just childhood cancer. So we might look at how, for instance, horizontal policies to build up the child cancer system through child health workers impacts upon or integrates with efforts to deliver care for kids with cancer, all the way from early diagnosis at the primary care level through referral to tertiary care centers. So I won't belabor it overly. I can send you kind of those modules if you're interested. One nice thing about them is they're available in modular format. So if you're interested, for instance, in looking specifically at the health workforce, we can pull modules from each of those tools to take a deep dive into that. We're hoping to ultimately have these available as kind of a global public good with an online database where you can pull those modules for doing research of that sort.
Thank you for this panel. This is great. So I'm actually one of those people who thought that cancer is rare. It's so expensive. And, so I fit that kind of profile. So this question comes like, one of the things that I was interested in is how many children do you think are missed as far as diagnosis? Because you do have it comes, you say this is cost effective, but how many are missing?
The short answer is that we don't know. And that there are many.
And we debated endlessly.
And we debated endlessly. So yesterday we were just trying to do some simulation and some modeling to help us understand better how many children we are missing. As you know, diagnosis of a child with cancer, requires a whole set of components. First you need to decrease the competing risks of illness and death, and then so many other components within the health system. So I don't know if we have a proper estimate. We think that many are missed, maybe 1/3, maybe more, I don't know. But definitely we are using now some modeling to help us understand exactly what is that gap in knowledge. I don't know if...
So as Carlos very rightly says, we don't know. There is, and it's obviously a very challenging area of research. How do you find somebody who's not been diagnosed? Now there is a project which I have encountered somewhere, I don't know whether that's finished or not, where somebody is looking at 5,000 slides of children with anemia, stroke, malaria in Africa, and seeing how many of them had blasts in them, and they were not picked up. So that's one way of, you can try and see, people who probably never got diagnosed with leukemia and were missed as malaria. So, but that kind of research is difficult to do and difficult to measure. The other one, which is, or a similar question is, this is the incidence of cancer in your particular country. How many children are being registered? That is a relatively easy one to answer, although again there's an imperfection in that. And that's easy to answer because you can argue that the childhood cancer incidence is broadly similar. And so if your incidence is 80% or 70% or 60% of the global incidence, then you're probably missing that many number of patients, particularly if you've got particularly female underincidence or rural underincidence, so you know that those groups are the ones which are getting missed. So the challenge with diagnosis is that you may not be registered on a cancer registry, but you will be diagnosed in a particular hospital. And so hence it's difficult to quantify the undiagnosed patients. Thank you.
So I think just in the interest of time, we'll cut it off there. I'll end by thanking, but one thing I'll just want to echo is what Avi said about the impact of this kind of work. We're clinicians as well, but the Ghana project that Avi brought up in terms of costing, when we were talking with our Ghanaian collaborator about what she was going to do with this cost data, where we showed that it was very cost effective even by Ghanaian GDP standard and stuff. She says, oh, well, we were planning meetings with the Ministry of Health and using this data hopefully to convince them to include childhood cancer treatment in their universal healthcare insurance program. And our first thought was, my first thought I should say was, oh, well, that would make that the by far most impactful research I've ever done. And then the second thought was, I'm probably never going to do anything more impactful than this as well, right? But I think it's just a nice example of a relatively simple study using methodology that's well known in other aspects of medicine that we haven't taken advantage of and that we probably could. And I think that applies for a lot of the fields that people represent here. So I'd like to end by thanking our 4 panelists who have come, some of them a very long way, had 3 very busy days that we're in the midst of, and taking even more time within those days to come do this panel. So thank you very much.